e-learning for trainees, which is a successful feature of the Anesthetic Society being telecasted for you, that is especially for the trainees, every fortnightly, to witness a postgraduate presenting a case or facing OSCE exam as a prelude to the final exam. So this makes the students confident to face their exam and to make them familiarize with what is the common questions being asked in any case. So those who are in first year, they can start listening to these case presentation and make them very comfortable by the time they reach their final year exam. So today we have the TED Talk 6th session, which is a case discussion on mitral stenosis in a pregnant woman, which is a very common scenario which is kept in every practical examination possible. And even if we have a non-pregnant patient with mitral stenosis also, the discussion will go into pregnant patient with mitral stenosis, which is a very common case discussion. So this becomes a very important session for postgraduates to follow. So for us to examine the candidate, we have with us Dr. Amarja Nagre. She's a consultant cardiac anesthesia at Kamal Nayan Bajaj Hospital, Aurangabad. Welcome, Dr. Amarja.
Thank you, sir. Thank you so
much. Good evening. I think
evening.
Back from your night duty, you have taken enough pain to join us. And thank you for joining us today evening.
My pleasure, sir. Thank you. Thank you so much.
And we have Dr. Vijay Kumar Ranganathan. He's a consultant cardiac anesthetist at KG Hospital, Coimbatore. Welcome, sir. Good evening.
Good evening, sir. It's a nice program you are organizing for a long time. It will be very useful for all the postgraduates all over India.
Thank you. Thank you for your support, sir. And I should thank you for sponsoring your postgraduate and encouraging her to present in this session. So Dr. Vijay Kumar will act as more of an internal examiner and Dr. Amarja will be acting more of an external examiner. Okay?
Yeah.
So more of vigor and more of action expected.
Yes, sure.
And the person who will face the examiner of the candidate, the main heroine, Dr. Meera. She is a final year PG who is about to appear for her exam this December.
Okay.
And she is pursuing her postgraduate at KG Hospital, Coimbatore. Welcome, Dr. Meera. And I should really congratulate you for presenting this case and facing bravely the examiners in public audience. It's almost like a PhD Viva OC. So you will be like presenting your case and facing questions in public. So this is a big training program. So whatever you answer right or wrong will be taken in good stride. Okay?
Yes, sir.
So nothing to be, inhibited or something. Even if you don't know, you can just say no, I don't know. And there are examiners who will explain it to you. So it's a practice session before the final exam.
Yes, sir.
All the best for your case presentation.
Thank
you. I stop my share. Okay?
Yeah.
And you can share your presentation.
Yeah. I think, can you see the screen?
We could see the presentation, yeah.
Yeah.
So I hand over the session to you both.
Okay, Dr. Meera, you can start presenting.
Okay. Good evening all. So this is about Mrs. Ramya, 23 years old, female, primate with 36 weeks of gestational age, a teacher by occupation, residing at Coimbatore, has come for safe confinement. History of presenting illness. Patient came with history of 9 months of amenorrhea, complaints of breathlessness since 3 months duration, palpitation since 1 month duration, and easy fatigability since 2 weeks duration. Breathlessness was gradual in onset over 3 months, progressive in nature, which was aggravated on exertion and relieved on rest. Patient was initially comfortable at rest. She had a history of mild limitation of activity, and it was now progressed to moderate limitation. So it suggests transformation of grade NYHA class 2 to class 3. And palpitation was since 2 months duration. It was insidious in onset and aggravated on exertion and decrease on rest. and feeling generalized weakness for the past 2 weeks. Tiredness increase on activity and she feels better on rest. There's no history of fever, hemoptysis, orthopnea, paroxysmal nocturnal dyspnea, chest pain, or syncopal attacks. No history of change in voice or difficulty in swallowing. No history of recurrent respiratory tract infection. No history suggestive of squatting or cyanotic spells. Past history, patient gave history of fever with sore throat and joint pain involving both the knee joints at 12 years of age. She was hospitalized for the same and she was diagnosed to have rheumatic fever and was advised penicillin prophylaxis once in 21 days. She took the injection for 5 years and discontinued on her own. And she is not a known diabetic, hypertensive, bronchial asthma, tuberculosis, epileptic, or no previous history of transient ischemic attack. Present medical history, she is booked and immunized. She developed difficulty in breathing and palpitation in the second trimester, for which cardiologist opinion was sought, and she was investigated and diagnosed to have heart problem, and she was started on medications. Her obstetric history, first trimester, it was spontaneous conception. Pregnancy was confirmed by urine pregnancy test at 45 days of amenorrhea. Booked and immunized. She took her iron and folic acid regularly. No history of radiation exposure or no history of bleeding per vaginal. On second trimester, she was able to perceive the fetal movements at 20 weeks of gestation. Anomaly scan was normal. No history of headache, swelling of limb, blurring of vision, no history of bleeding or draining PV. She developed breathing difficulty and palpitation during second trimester, and the cardiologist opinion was sought and diagnosed to have heart problem and prescribed medications and injection. She's on regular follow-up with both the doctors. Third trimester, she continued to feel fetal movements well and no history of lower abdominal pain and no history of bleeding or draining PV. Her drug history, folic acid and iron tablets along with tablet metoprolol 25 mg twice a day, tablet pentit 400 mg twice a day, tablet diator 10 mg twice a day, tablet digoxin 0.25 mg once a day, serum potassium chloride 2 teaspoons once a day, and injection low molecular weight heparin 40 mg subcutaneous once a day. Her
What is Pendid? Dr. Meera, let me just ask you, what is Pendid?
so penicillin.
Fine.
Surgical history, she has not undergone any surgeries in the past. Personal history, patient takes mixed diet, normal bowel and bladder habits, reduced sleep and appetite since 2 months duration, no history of substance abuse. Family history, no significant family history. Her menstrual history, she attained menarche at 14 years of age, regular cycles 3 by 30 days, no history of dysmenorrhea or menorrhagia. Her last menstrual period was on October 28, 2019, and expected date of delivery August 4, 2020. Marital history, she's married since 2 years, non-consanguineous marriage, no history of any contraceptive usage. On summarizing, she's a 23 years old preemie with probably rheumatic valvular heart disease in atrial fibrillation and in compensated state, admitted with 9 months of amenorrhea for safe confinement.
Okay. This is, I think your history presentation is over.
You're summarizing your history,
Yeah.
right?
Yeah.
Yes. So how do you get to know that it is a rheumatic valvular heart disease?
First point is, since there's a positive history of rheumatic fever in the past, and patient complaints of breathlessness and features of palpitation which suggest atrial fibrillation, and she has given history of penicillin therapy in the past. So it's more likely of rheumatic heart disease.
Okay. So what we have to do is, on history, you cannot jump directly to rheumatic heart disease. You can just say that you have to consider first if it is respiratory origin or if it is cardiac origin, right? So
Yes.
now here it is very much evident that it is cardiac origin. But tell me why it is not respiratory, this dyspnea and everything, why it is not respiratory? Now you can tell the positive findings of your cardiac. Yeah. Tell.
In case of respiratory cause of dyspnea, it will be usually preceded by sputum or cough with expectoration.
Very good. Very good.
And patient will be having history of respiratory disorder in the past, like bronchial asthmatic or history of family history of atopy. And aggravating and relieving factor, they will get relieved by use of inhalers.
Yes.
Whereas in cardiac cause, it will not be preceded by any cough or expectoration, whereas breathlessness will be the initial symptom, which may be followed by cough. and
Yes.
they'll have associated features like paroxysmal nocturnal dyspnea or orthopnea.
Very good.
And dyspnea will get exerted when on exertion, like exercise and all.
Now I'll tell you how you come to the diagnosis. Like, tell me if it is left heart involvement or right heart involvement, according to history only.
In right heart involvement, there'll be facial puffiness, or on
Yes.
examination, there'll be elevated JVP, pedal edema, and patient may complain of abdomen pain. So
Very good.
epigastric tenderness may be
So there
there.
will be signs of right-sided failure, right?
Failure, yes,
Yeah.
ma'am.
And left-sided?
Let's say patient will complain of breathlessness, which may be severe on exertion, and paroxysmal nocturnal dyspnea will be present on
So
early
here,
stages.
so here it looks like which side is involved?
More of left side, ma'am. There's no features of right heart
So
involvement.
in left side now, two valves will be there,
Yes,
mitral and aortic, right?
yes,
So
ma'am.
in this, which valve will be involved? Most probably?
In rheumatic, it is most commonly mitral
Yeah.
valve involvement.
So because I think it is rheumatic, it might be mitral, one. And secondly,
Or
usually dyspnea patients have mitral involvement more.
yeah, okay.
For aortic, dyspnea comes last. Okay.
Yes,
Yeah.
ma'am.
Now again, from the history, you can again say if it is a regurgitant lesion or a stenotic lesion.
Yes.
Now tell me how you will say. Just
Uh,
think.
in case of a patient will be having low cardiac output in stenotic lesions, so increased fatigability and history of syncope may be
Okay.
there.
Yeah. Dyspnea. And if it is like mitral and aortic, we are saying, na?
Yes,
In
ma'am.
aortic, it is more of palpitations type.
Angina, palpitation.
Yeah, got it.
Yes,
And
ma'am.
sorry, stenotic and regurgitant.
Regurgitation.
Regurgitant more it is palpitations, while stenotic is morely dyspnea.
Yes, ma'am.
Got it. So
Yes,
here
ma'am.
only you get to know that it is cardiac involved, it is left-sided heart involved, it is mitral involved, and it is a stenotic lesion.
Yes.
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 Now one more thing you have added, that you know it is atrial fibrillation.
Yes.
How do you say it is atrial fibrillation on history?
Since patient tells she could feel palpitation
Oh,
and
yes. So
and
probably it might be atrial
might be
fibrillation.
atrial fibrillation.
It can be any arrhythmia, right?
Yes, ma'am.
Yeah. So we cannot just comment like that because you haven't seen the, you haven't
ECG
yet
or
done the examination.
yes,
So
ma'am.
don't say atrial fibrillation as of now only. In
Yes.
compensated heart, admitted with what it is? Admitted
9
with,
months of amenorrhea. 9
yeah,
months of amenorrhea.
9 months of amenorrhea. It's safe confinement. Okay, fine. You got it?
Yes,
All
ma'am.
4 points? Yeah.
Yes.
Thank you. You can proceed. Sir,
Yeah.
over to you.
Yeah. I will discuss a few things about rheumatic fever. Because if it is a rheumatic fever,
Yes.
how do you say it is rheumatic fever? What history suggests you that it is a rheumatic fever?
So
Hello, can you hear? I think Mira got
I
disconnected.
think it's, yeah.
1
It
minute,
got
can
stuck,
go.
I think. Yeah.
Yeah.
Okay.
Sir, can we pause? Can we pause?
Yes, sir. No problem.
Yeah, 1 minute.
You can go ahead.
Yeah, now Mira, tell me how you evaluated a patient for the past history of rheumatic fever. What are the history you took?
So a history of fever with sore throat, or a history of joint pain, involuntary movements, or any presence of subcutaneous nodules in childhood.
Okay.
What it is called as?
Subcutaneous nodules,
All
erythema,
these things are called as collectively what? What
major
criteria?
criteria for in rheumatic fever. Jones criterion.
Very good. Yes.
Duckett Jones.
Yes.
Okay. So, what are the Jones criteria?
So it
How it
consists
is
of
divided?
major criteria and minor criteria. Major criteria contains carditis, arthritis, Sydenham's chorea, erythema marginatum, and subcutaneous nodules. Minor criteria, presence of fever or a history of rheumatic fever in the past, arthralgia, laboratory investigation like raise ESR, CRP, and prolonged PR interval, along with evidence of any streptococcal infection,
Okay.
positive throat culture.
Okay. You are telling about antibiotic prophylaxis. Usually,
Yes,
what prophylaxis is given for secondary prophylaxis post rheumatic fever?
It is a benzathine penicillin G 1.2 million unit will be given intramuscularly once in 21 days. Or penicillin V potassium orally 250 mg BD can be used.
For how much duration?
For 21, it is depending upon the whether presence of carditis or
Yes.
residual lesion. If only rheumatic fever and no cardiac involvement, it should be given for 5 years post attack or up to 21 years of age. In case if rheumatic fever along with carditis, it should be given for 10 years or 21 years of age, whichever is longer. If patient has rheumatic fever and any residual lesion, it should be given for 10 years or 40 years of age, whichever is longer.
Okay. Okay. How do you define rheumatic heart disease or rheumatic fever?
It's a acute non-suppurative immune-mediated inflammatory reaction, which will usually follow a pharyngitis, and it is commonly seen in school-going children.
Caused by?
Group A beta hemolytic streptococci.
Fine. Okay, you can proceed.
Yeah. Now, the patient was on different drugs, no?
Yes, sir.
I think the cardiologist would have put so many drugs. Do you know why each drug is put for this patient? There should be some reason behind it.
This cardioselective beta blocker to
You can
reduce
show
the
the slide of drugs.
Yeah.
People can relate to it. Okay, it is a bit tedious, right? Here.
Yeah.
This cardioselective beta blocker to reduce the heart rate, to have control on heart rate, and penicillin for antibiotic prophylaxis, and tablet diet or diuretic to prevent pulmonary edema or pulmonary congestion, and for digoxin or cardiac failure, and digoxin it is for also heart rate control. And since patient was on long-term diuretic, she might have hypokalemia, so potassium chloride, and low molecular weight heparin, it is for prevention of formation of left atrial appendigeal thrombus or clot. And since she is pregnant, it is also a hypercoagulable state and high chance of embolic complication.
Yeah. Good.
Fine.
So, okay. How do you grade dyspnea?
So dyspnea is graded upon New York Heart Association classification, which has 4 components: angina, dyspnea, syncopal, and fatigue. So NYHA class 1 is there is no limitation of physical activity. NYHA class 2 there will be mild limitation of physical activity. NYHA class 3 there will be moderate limitation of physical activity. Patient will be comfortable at rest, but on less than ordinary physical activity will produce those symptoms.
And say a full sentence all 4 times.
Okay.
Yeah, that is very important. Yeah.
Yes.
Because if you say mild, moderate, then you will not miss anything. You have to say the full thing. That is important.
Yes.
Okay. Okay. You can try.
Okay. And class 1, it is there's no limitation of physical activity. Ordinary physical activity does not produce any syncope, fatigue, palpitation, or angina. NYHA class 2, there will be mild limitation of physical activity. Patient will be comfortable at rest, but ordinary physical activity will, it will result in fatigue, palpitation, or dyspnea. And class 3, it is marked limitation of physical activity. Less than ordinary physical activity will result in fatigue, syncope, and angina and dyspnea. Class 4, she will not be able to carry out any physical activity. So she'll be symptomatic even at rest. And there will also be presence of paroxysmal nocturnal dyspnea or orthopnea.
So good. So whenever a third person is listening to your exam or examiner and you, okay, if he's not looking at you, he should only hear your voice, not the examiner's voice. So wherever you get a chance to explain things and you know about it, you should not let go that chance. Got it? You have to grab that chance, and whatever you know, you just have to keep on speaking, right?
Yes.
So you have learned it for 3 years, no? So just speak. Yeah. Proceed.
Now, you're told about orthopnea and paroxysmal nocturnal dyspnea.
Yes.
Okay. So, what is orthopnea and what is the mechanism behind it?
So orthopnea, it is because of dyspnea and lying down position. So patient will feel dyspneic soon after lying down, and it get relief soon after in sitting posture. So this is because when the patient goes on a recommend position, the peripheral circulation will get shifted, extrathoracic circulation will get shifted to intrathoracic. So since the patient has a stenotic lesion, they may go in for dyspnea on lying down posture, and it is equivalent to NYHA class 4.
Okay. What about paroxysmal
What is
nocturnal dyspnea?
PNDS?
PND is paroxysmal nocturnal dyspnea. So usually patient will develop difficulty in breathing after about 2 to 3 hours of sleep in deep sleep, and it gets relieved only about 20 to 30 minutes after attaining the supine posture. And this is because when the during sleep the sympathetic activity will be reduced, and the respiratory centers also get depressed. So the left ventricle will not be able to cope up with the cardiac output. So patient will feel breathlessness, and it gets only relieved after 20 to 30 minutes of sitting posture. And this also comes under NYHA class 4. The early feature of left ventricle dysfunction. Patient is going for left ventricle dysfunction.
Yeah.
Okay.
I just forgot to ask you one question in rheumatic. Like, what is the period of manifestations of this rheumatic activity in a patient? Like,
It approximately takes a decade, that is 10 years, for the development of valvular lesion from the onset of rheumatic fever.
yes.
Yeah.
So sometimes it is like more than a decade, because unless and until these are poor socioeconomic status patients, right? Unless and until they get symptomatic, they don't approach the hospital.
Yes.
So yeah, by the time they develop this dyspnea, it is almost like 15 to 20 years. Yeah.
Yes.
So
Yeah.
the rheumatic has already set in, and it has already affected the valves.
Yes, ma'am.
Yes. So you find this mitral stenosis or this patients like having mild to moderate disease already. Yes. So the period is very long. Yes.
Yeah.
Okay. Yeah.
Then you have idea what is infective endocarditis?
It's a serious infection which is characterized by colonization or invasion of the cardiac valves or the mural endocardium by a microbe.
Okay.
Does your patient have infective endocarditis from the history point of view?
No, ma'am.
What did you expect? What do you expect if he has infective endocarditis? How did you know?
Should have told history of any a fever
Very good. Yes. And
or nodules, painful nodules in the fingertips, or presence of any hematuria or immunological involvement like hematuria, hemiplegia,
or something like stroke or something because of
yeah,
Yes.
agitations might, yeah,
embolic complication.
embolic phenomena can occur. Yeah. But mostly it is the fever. Yes.
Yeah.
Fever associated. So that is like even after treatment the fever doesn't subside, then you think of
Infective.
infective endocarditis. Then these patients also have the history of past BMV or something like that.
Yep.
Yes, it is infective endocarditis is more common in them who have
Subarachnoid
some or the other procedures done on the mitral valve, like BMV, CMV, OMV, or prosthetic valve. Yes. So if you have all this in history, you should always keep in mind that infective carditis can be, endocarditis can be present. Yeah.
Yeah.
Okay.
So, ma'am was telling about infective endocarditis, different procedures. What are the procedures which you will give infective endocarditis prophylaxis?
When the patient had a history of previous infective endocarditis, or a patient is a known case of valvular disease with prosthetic valve, and a cardiac transplant patient with dysfunctional valves, or a congenital heart disease patient with valvular disease, or a congenital heart disease patient rheumatic repaired lesion with prosthetic valve, or a known case of congenital heart disease with residual lesion. So all those patients should get prophylaxis for infective endocarditis.
Okay. What are the patients you will not give infective endocarditis prophylaxis? Some procedures you may not give, need not give.
Patients who are undergoing dental picking, that is, there's no manipulation of gingiva, or upper GI endoscopy, bronchoscopies, or elective clean surgeries like lower section cesarean segments or IOCD insertion. So clean surgeries.
You may not. Yeah. Okay.
And you said this patient is in compensated rhythm, isn't it? So, what made you to say it is the patient is in compensated rhythm in history? What are the things you
Since the patient is comfortable at rest and she had no history of dyspnea and lying down posture, or there was no history of paroxysmal nocturnal dyspnea, and no features of raised JVP. So it is more of a compensated heart.
Okay, you cannot comment about JVP in
ABP in
history.
history. We are still in
Yeah.
history.
Yeah, so should say only about orthopnea, comfortable rest and
That's
PND.
it.
Okay.
And you can just
Yeah.
say other right-sided heart failure or signs of heart failure are not present, which can be left-sided this, right-sided this, like that.
Yes.
Yeah.
So one more thing I just wanted to ask is, one of the histories her complaint was the tiredness.
Yes.
So what could be the possible reason for
So
that?
there may be two causes for her tiredness. One is because of a decreased cardiac output because of stenotic lesion. So cardiac output was decreased, and one will be since she's pregnant, there may be underlying physiological anemia of pregnancy. So
Yes.
both might lead to fatigue or syncopal attack during pregnancy.
Okay.
Tiredness or fatigue. That's it.
Yeah. Okay. You want to add anything? Any questions or anything you want to?
Yeah.
Or shall?
Yeah, we can proceed to next general examination.
Yeah.
On general examination, after obtaining consent, patient was examined in a well-lit silent room. Patient conscious, oriented, afebrile and cooperative. She is moderately built and nourished.
Again disconnected.
Yes.
Oh my God. Again she got disconnected.
Yeah.
There is some internet issue for her, I think. Just 1 minute, just check it out again and come.
Okay, no issues.
Yeah.
24. Pulse rate is 82 per
Yeah,
minute.
Yes.
I think your internet was a little problematic. You got disconnected. Again, can you present from first? Your internet got
First one,
disconnected.
patient is conscious oriented. You can start.
Yeah.
Okay. Patient is conscious, oriented, afebrile and cooperative. She is moderately built and nourished. No pallor, cyanosis, clubbing or lymphadenopathy. Pitting pedal edema is present. There are no markers suggestive of rheumatic fever or infective endocarditis. Thyroid, breast, hair and skin normal. Spinous process palpable, no spinous deformity. Peripheral veins are visible for cannulation. Her weight is 55 kgs, height 151 centimeters and BMI of 24. Vitals, pulse rate of 82 per minute, irregularly irregular, varied volume, non-specific character, pulse deficit of 10 per minute. There is no radial or radiofemoral delay. All peripheral pulses are felt. Blood pressure 100 by 50 millimeter of mercury, which was measured in left upper limb in sitting posture. Respiratory rate 20 per minute. JVP not elevated and metabolic equivalence less than 4. Airway examination. Normal facial symmetry, bilateral nasal patency present. She has full range of neck movements, mouth opening of 3-finger breadth, Malampatti grade 2, no loose teeth or dentures. Obstetric examination.
We'll go to systemic examination little
Yes, we
later,
will
I think.
discuss the systemic examination. So,
Yeah.
what are the positive findings that support your diagnosis?
Ma'am, sorry.
What are the positive findings in the general examination that support your diagnosis?
On examination,
history?
yeah, on vitals examination, heart rate is 82 and it is irregularly irregular. And since the patient had a history of palpitation, it may be because of atrial fibrillation and varied volume, which suggests it may be a stenotic lesion, and it is non-specific character, and pulse deficit, which is more suggestive of atrial fibrillation.
Okay, so how do you elicit pulse deficit?
So for eliciting pulse deficit, we need to examine us. So one should be auscultating the heart rate, and simultaneously one should palpate the radial artery pulsation. So the difference between two will be, it is defined as the pulse deficit. If pulse deficit is more than 6 per minute, it is suggestive, it is significant of atrial fibrillation.
And if there is only one examiner, always you can't have somebody with you to examine, okay? Or in your private practice for your calls or freelancing, there will be nobody, so you'll be alone. Then how will you elicit? No, you have to do it simultaneously. You have to auscultate at the apex bit and you have to see for the pulse, okay? And then only calculate the missed bits.
Okay.
Got it? That is one thing. That is actually authentic one. The other method is also what we were taught is take it in 2 cardiac cycles and then see the difference. But the authentic is the first one, when you have to do at one go. You have to auscultate and palpate for the pulse and see the how much deficit is there. Right?
Yes.
Yeah.
One moment. Here are matches for deficit.
Yeah.
Yeah.
Proceed.
Yeah.
Okay, sir. Yeah.
Yeah. What's the reason you wanted to palpate all the peripheral pulses?
Yeah.
To rule out any thromboembolic events because of atrial fibrillation. So to rule out that, all peripheral pulsation was examined.
Okay.
Because of atrial fibrillation, why did you say that? Say the whole sentence once again.
To rule out any, because of atrial fibrillation or thrombus clot, which would have, or in case secondary infective endocarditis, when thrombus are there, it may dislodge and may cause.
Okay. Okay. So whatever the thrombus is going to form, it is not only due to atrial fibrillation. Okay. So you in the pathophysiology we'll come again, we'll discuss in detail. But as of now, don't say due to atrial fibrillation. Just say for any thromboembolism or if there is any embolism of the thrombus or the vegetation, like that only you say. Okay. And why is the varied volume, or why the volume is less in the pulse? Like why are they low volume? What is it called as? It's called as parvus.
Parvus et
No, parvus. I knew you.
That is aortic stenosis.
Yeah, parvus et tardus is aortic, and here it is only parvus. Okay, so it is parvus. Why? Why it is low volume?
Because of stenotic lesion, the left atrium will not be able to completely empty into left ventricle, so the stroke volume will be reduced.
Yes.
So reduce cardiac output.
So you have to use the specific words, okay? Because of less stroke volume due to relatively fixed cardiac output state.
Yeah.
Got it? Use
Yes.
specific words so that you get more and more questions to answer. Yeah, and it creates a very good impression. So the stroke volume is less because of relatively low cardiac output state. Okay. Why relatively? MS is a relatively, okay? And AS is low cardiac output state. Got it? AS is low cardiac output state. MS is relatively low cardiac output state. Fine? Okay. Next.
Can you define cyanosis?
Cyanosis is defined as bluish discoloration of skin and mucous membrane. So it occurs when the reduced hemoglobin fraction is more than 5 gram per deciliter percent. And cyanosis of two types, peripheral cyanosis and central cyanosis. So in central cyanosis, it is because of reduced PaO2, and in central cyanosis. In peripheral cyanosis, it is because of reduced cardiac output or when there is exposure to cold environment.
So in this case, there may not be cyanosis, but something similar might be present in mitral cases.
Mitral phases will be there because of reduced cardiac output.
And reduced cardiac output and
stagnation,
vasoconstriction. Peripheral vasoconstriction. There may be bluish
mitral phases
of the chicks called as mitral phases.
Yes.
Fine. Anything you want to say about JVP? JVP is not raised in this patient actually.
Yes, ma'am.
If it was raised, what it would suggest?
So JVP, it is surrogate of it elicit the right atrial pressure or the intravascular status of the patient. So JVP consists of 3 positive waves and 2 deflection, that is A, C, and B. So A wave corresponds to the right atrial contraction, and C wave corresponds to the isovolumetric ventricular contraction, and X wave it is to atrial venous filling, and why will be it is because of the rapid ventricular filling.
Okay. Okay. Fine. And mates less than 4. What does that mean?
So metabolic equivalence, it is usually used to elicit the functional capacity of the patient. So with the help of that, we can interrupt any preoperative or perioperative cardiac complication.
What is MET? How is it classified?
Metabolic equivalence, it is classified as depending upon the patient functional status, like if she is able to carry out her own routine works or able to walk and dresses and eats or singing,
No,
playing.
you have to tell it according to the flight of stairs. That only one criteria you can discuss all less than 4, 4 to 10 like
Less
that.
than 4 metabolic equivalent is poor functional reserve, and 7 to 10 will be moderate functional reserve, and more than 10 it is excellent functional reserve. So accordingly, patient will have reduced or
So
increased perioperative risk.
yeah, for now it is okay, but next time when you say, you have to say how much physical activity can be done in terms of flights of stairs.
Yeah.
Yeah, how much they can walk, and the met how much it corresponds. Okay.
What is one metabolic equivalent is equal to?
So it is defined as oxygen consumption in ml per kg per minute, so which is roughly equal to 3.5 ml per kg per minute.
Okay. And Malambati grading, you were telling something you have to ask about anesthesia. Mostly it is all medicine. So how do you grade this Malambati grading?
So it's a scoring system which relates with the adequacy of mouth opening to the size of the tongue and ease of the space available for the ease of laryngoscopy and intubation. So Malambati grade 1, it is there will be complete visualization of the hard palate, soft palate, uvula and the fascial pillars. In 2, it will be the hard palate, soft palate and the base of the uvula. In 3, it will be only the hard and soft palate, and in 4, there will be only visualization of the hard palate. So 3 and 4, there will be a high risk of difficulty in intubation or scopy or intubation.
So what is modified Malampatti classification?
So this is modified Young's classification, Malampatti classification.
Okay. Why did you see the nasal this thing patency?
In case if it is difficult oral intubation, we can go for nasal.
This patient you were telling pedal edema was there, no?
Yes.
Yeah. Is it physiological or is it related to cardiac cause?
Since this patient had no symptoms suggestive of right ventricular failure, like there is no symptoms of raised JVP or paroxysmal nocturnal dyspnea or orthopnea, and she was comfortable at rest, it is more likely physiological cause of pedal edema.
Okay.
This patient had a hemoptysis? No, no?
No history of hemoptysis.
What are the causes of hemoptysis, if at all it is present?
So in mitral stenosis, because of the increased left atrial pressure, which get transmitted to the pulmonary artery, so long-standing pulmonary artery may cause pulmonary hypertension. So there'll be rupture of bronchial veins. So patient may present with hemoptysis.
Okay, and
Whenever there may be history of pulmonary embolism or pulmonary infarct may also present, or pulmonary edema where the alveolar capillaries are ruptured and they may present with hemoptysis.
Pulmonary edema thing, yeah? Pulmonary edema, pulmonary infarction, bronchitis, and what is pulmonary apoplexy? I wanted you to utter that word.
Pulmonary apoplexy, there will be sudden increase, hemoptysis will be there, which is spontaneously patient will recover from that.
Why does it occur? What is pulmonary apoplexy?
And it is
Left atrial pressure, what happens?
it will be transmitted to the pulmonary venous and the pulmonary arterial pressure. So because of
Yeah,
rupture of veins, bronchial
pulmonary veins, yeah, and bronchial veins will occur, which is called as pulmonary apoplexy.
apoplexy.
Okay, next.
Then, yeah, now I have to go to, yeah.
Obstetric.
Obstetric examination, inspection, abdomen longitudinally enlarged, umbilicus and midline, flushed with surface, linear nigra present. No scars or sinuses visible. Fetal movements visible during examination. On palpation, fundal height correspond to 38 weeks of gestation. Fundal grip, broad, firm, bulky, rounded, non-palatable mass felt, suggestive of breech. Lateral grip, hard, resistant, slightly curved mass felt on left side, probably the back. Irregular firm nodules felt on right side, probably limbs. Pelvic grip, hard, globular, independently palatable mass felt, suggestive of head. On auscultation, fetal heart rate of 160 per minute, which was heard below and left of the umbilicus. On cardiovascular examination inspection, apical impulse seen at left fifth intercostal space in midclavicular line. No precordial bulge, no visible pulsation or distended vein seen, no scars or sinuses seen. On palpation, apex beat confirmed at left fifth intercostal space in midclavicular line. It is tapping in nature. Thrill felt in mitral area and left lateral portion during expiration. No parasternal heave, no chest wall tenderness. On auscultation, mitral area, loud S1 heard followed by S2, opening snap heard, low pitch rough rumbling mid diastolic of grade 4 intensity heard over mitral area in left lateral portion with bell of stethoscope heard at end of expiration. In all other areas, S1 and S2 heard with no added sounds or murmur. On respiratory system examination, normal vesicular breath sounds heard with no added sound. On central nervous system examination, higher mental function examination, normal. Diagnosis, a 24 years old priming with 38 weeks of live intrauterine gestation with cephalic presentation with compensated rheumatic mitral valve stenosis with atrial fibrillation, admitted for safe confinement.
You have to complete it with saying CCF, no evidence of congestive heart failure with no evidence of infective endocarditis. These 2 points also usually we add. Okay. So from your examination now, what is your inference?
So patient is in mitral stenosis following rheumatic fever, and during on examination and investigation, it comes under mild to moderate mitral stenosis and not in failure, and patient is having atrial fibrillation.
Okay, okay.
So, what's a normal mitral valve area?
It is 4 to 6 centimeters square.
Okay.
And how do you classify the mitral stenosis?
So mitral stenosis based on mitral valve area classification is when the mitral valve area is 1.5 centimeters square or but less than normal, it comes under mild mitral stenosis. If it is between 1 to 1.5 centimeters square, it is moderate mitral stenosis. If the valve area is less than 1 centimeter square, it is severe mitral stenosis. And if it is less than 0.8 centimeters square, it is critical mitral stenosis.
Okay. According to pressure gradient?
According to pressure gradient, mild will be less than 5 millimeter of mercury, and 5 to 10 will be moderate, and more than 10 millimeter of mercury is severe mitral stenosis.
Any other criteria is there?
On the systolic pulmonary artery pressure, mild will be less than 30, and moderate will be 30 to 50 millimeter of mercury, and more than 50 will be severe. And based on pressure half time, if it is less than or equal to 100 millisecond, it is mild. Moderate will be 100 to 200 millisecond, and if it is more than 220, it is severe.
Okay. So, do you know what is pressure half time and all?
It is with the help of Doppler flow across the mitral valve, the E wave and the time taken for the peak wave to come to reduce to half. If that is prolonged, that is taken as a pressure half time.
At this moment, if you know it, then only comment about it. Otherwise, you should not comment. Okay, because whole of the viva is remaining, right? Yeah. So don't say pressure coupling at this moment. Fine. Yeah. And okay. And is it the peak? You said systolic. You said the systolic pulmonary pressure. Is it the systolic or the mean?
Mean, ma'am.
Yeah, it is mean. Yeah. Okay. Fine. And what more, sir? Sir, proceed.
For any mitral valve stenosis, at what mitral valve area the patient will start presenting with symptoms?
So usually when the valve becomes half its normal size, it is around 2.5 centimeters square, where patient begins to get symptoms on severe exertion.
Okay, so you have examined this patient. What could be the mitral valve area? Any possible?
Since this patient is comfortable at rest and she had no history of PND or orthopnea, she comes under mild to moderate mitral stenosis. So it may be around 1.5 to 2.5 centimeters square.
Okay, from examination point of view. Okay.
Can you describe the anatomy of mitral valve?
So mitral valve, it's a bicuspid valve which is present between the left atrium and left ventricle. It consists of two leaflets, that is anterior leaflet, which forms 2/3 of the valve, and posterior leaflet as 1/3. And both the leaflets are combined with the help of posterolateral and anteromedial commissures, and which in turn gets connected with the two papillary muscle with the help of caudate tendinae.
And?
In the posterior leaflet, it is divided anatomically into 3 scallops, whereas anterior leaflet correspondingly it is divided into A1, A2, A3, and P1, P2.
That was about leaflets and subvalvular apparatus. That also you have to say. The annulus, papillary muscles,
caudate.
Caudate. Sir,
yeah,
we will discuss some like auscultatory findings, and that we have to discuss yet.
Yeah.
Yes. So we will go back to that first, and then we'll resume the conversation on mitral valve.
Yeah.
Yeah. So even you can go to palpation.
Palpation, I think.
Yeah, she had.
Yeah. Okay.
In a mitral valve, like, see, can you differentiate only on inspection, like which valve may be present and what it if it is stenotic or regurgitant? Only on inspection, I'm asking.
If the apical beat shifted, and if there is presence of thrill, or
No,
by inspection,
there is no. Inspection you can't have.
Thrill is only palpation. Inspection.
The apical beat where the impulse is seen.
If it is silent, precordium is silent or it is not silent, like that you should say first. In regurgitant lesions, it may not be silent, right? Yeah. People, patients have palpitations and tachycardia, no? So precordium is not silent, it is seen. So patients with MR, AR, they might be evident. If they are thin chest wall patients, it might be evident, yeah? So in MS, it might be silent precordium. In AS also there might be bulging, or there might be some some activity seen on the chest. But MS has a silent precordium. Okay, fine. Palpation? Palpation, can you make out? AR, regurgitant or stenotic?
Yeah, ma'am. Regurgitation, there may be a thrill or hyperdynamic apical pulse.
Yeah, and the apex bit will be shifted.
Shifted towards.
Yes. Yes, even AS, it will be shifted. In MR, AR, it will be shifted. Yes? MS, it is not shifted usually. If it is standalone MS, it won't be shifted. So you can also differentiate that this is a standalone entity or it is a mixed lesion. That also we can elicit from this. Okay. Now, parasternal heave, what does that suggest in this patient?
If it is present, it may be because of right ventricular hypertrophy.
Very good.
Pulmonary arterial hypertension is a patient may have right ventricular hypertrophy. So presence of parasternal heave.
Diastolic shock in this. What is diastolic shock?
It is a presence of P2, that is pulmonary hypertension.
Yes.
Patient has pulmonary hypertension. It is called as
Yes.
diastolic shock.
Yes. So you didn't mention anything on that?
She had no features on. There were no positive finding, ma'am, so I didn't mention.
No, it is very important. No, these patients will have mitral stenosis, will have pulmonary hypertension. So you have to say, even if it is not there, you have to say about this palpable P2 or P2 in auscultation at least. Yeah. And do you do percussion in these patients?
No, ma'am.
Why? Okay, you see somebody doing percussion for this patient. Yeah, somebody is not knowing. They just thought that the pulmonary artery may be enlarged, and let me see if it is dull over there. So, do you recommend?
No, ma'am.
Actually, percussion is not done. Yeah,
Yeah.
but still, if I want to go and see, then can I do in these patients?
But usually in female patient, and
No,
we
no,
won't be able to elicit any positive.
no, no, no. Here, your thought process has to be like, here the patient may have thrombus. Yes. So because of your percussion, this thrombus may get dislodged
Dislodged.
and cause thromboembolism. So any cases where you suspect thrombus, percussion should not be done. Okay, that should be the ideal answer. Okay. Next, auscultatory findings. Tell me.
So
Very nice auscultatory findings. Now tell importance of each one of the word what you have written over there. Loud S1. What does that mean?
So because of the thickening of that mitral valve, so during the closure, it takes time to the tensed mitral valve. It takes time to close, ma'am.
Okay.
So there will be loud S1 and opening snap may be present because of that.
Okay. Loudest one does mean that your severity of mitral stenosis. What does it mean with regards to severity?
Loud S1 is, it is not severe mitral stenosis because the valve leaflet is still pliable. Hence
Yes.
the
So I
sound is
wanted
loud.
word. Specific use of words will create a good impression on the examiner, which will give you bonus marks. If you are going to get 5 marks out of 10, you will get 7 marks if you use this specific words like pliability. Got it? Loud S1 tells you the pliability of the mitral valve leaflets. Fine? Yeah. So loud S1 means that it is still pliable, it is still
Pliable.
within within
Moving.
mild to moderate.
Moderate
What
stenosis.
happens with as the disease grows or disease becomes more severe,
It becomes
these valves
calcified
become
and
thickened,
calcified.
fibrous, yes, yes. So the loudness is not there. Yeah, they become muffled. S1 is also muffled. Okay. What is opening snap?
Opening snap, it's a high pitch sound.
Yes.
So during diastole, when the valves get closed, it takes time for the both the leaflet to come to close because of the tensed leaflets.
Hmm.
So that will be present as opening snap.
Okay. So this is the sudden gush with which the blood has to come from the LA to LV. Okay. Then how the door has to open?
It should
Got it?
open.
So it determines the LA pressure also, opening snap. Fine. Then mid-diastolic murmur, what does that mean?
The intensity of mid-diastolic murmur will tell us the severity of mitral stenosis.
So wrong. Recorrect your sentence. Is it the intensity?
The duration between
Very good. Then why
S2
did you
and
it is the duration? Yeah, it is the duration of the mid-diastolic murmur that is going to tell you about the severity. Now, why duration you tell? Then you will not forget.
because
Why duration?
it will be kept open because of
Exactly. So, see, if this is the mitral valve, yeah, and now this is the mitral valve, right? 4 to 6 centimeters. Now it has become 0.8. Yeah. So the amount of blood, if 100 ml blood has to go from year to year, yeah, it is not the intensity, no.
Yes.
It is thickened, it is calcified. Intensity won't do anything here. So for 100 ml blood to go from LA to LV, it is the duration. Got it?
Yes.
You got my point?
Yeah.
So duration will be increased. I mean the murmur, the mid-diastolic murmurs duration is increased. So it is the duration. Now never utter word intensity in MS. Fine? You got my point, right?
Yeah.
Yeah. Then in left lateral position, why?
It is more heard over the left lateral position.
Why? Simple. The heart comes closer to the chest wall. Okay, as simple as that. With the bell of stethoscope at the end of expiration. You want to explain why at the end of expiration? Tell. Easy. Okay, you'll think and tell me later.
Yeah.
Only one point I'm giving it to you, okay? Okay. Now next. So you have to know each and everything in mitral. This is where if you answer properly, yeah, nothing like it. Tell everything S1, why S1 is loud, opening snap, and then the duration of the MDM. And then even you can tell about OS and that this is there, no.
Opening snap, S2 and opening snap.
Yeah, opening snap, that duration is there, no.
Severity.
That also for the severity, that I'll ask you later. That also is important, right? Yeah. Now proceed. So we have come to respiratory system. Fine. See, as an anesthetist in our cases, no, they used to say that you have to write detailed examination of RS because we are anesthesiologists, no. We can't write one sentence for RS like that. It was for our DM examinations. Yes. Agree, Vijay Kumar sir?
Yes, yeah.
Yeah, respiratory system has to be detailed. Okay, I'll tell you later how to write it. Yeah. CNS is okay. Nextly, CNS is important in this, right?
Yeah.
Because of
Thromboembolic complications
yes,
or history of hemiplegia.
yes. Many patients have it, and it is not like it is not seen. Many patients have it. Yeah. Next. So done. Yeah. So that was a diagnosis. Now.
Okay, I'll just start with some questions. Usually in pregnancy, mitral stenosis or mitral regurgitation, which will be better tolerated and why?
Mitral regurgitation will be better tolerated because of the physiological changes which occur in pregnancy. The systemic vascular resistance will reduce up to 20 to 30%. So the regurgitation gradient across the valve will be reduced. So patient tolerates mitral regurgitation well when compared to mitral stenosis.
Is it regurgitation gradient or regurgitation fraction?
Fraction, the flow fraction.
Yeah, it is a regurgitation fraction will come down.
Fraction. Yeah.
So,
Okay, so
what are the normal physiological changes which will happen in pregnancy?
The heart rate increases up to 15 to 25%. The intravascular volume increase up to 40%. The cardiac output up to 30 to 40%. And the stroke volume increase up to 40%. The systemic vascular resistance will come down by 20 to 30%. The central venous pressure and the pulmonary artery pressure remains unchanged. And the diastolic blood pressure comes up to down to 5 millimeter of mercury.
So in these changes, which would affect the pregnant patient very much, particularly in mitral stenosis? Some changes will affect more in pregnant patients.
So, because of increase in heart rate, the diastolic time will be reduced. So left ventricular filling will be reduced. So that will be followed by decrease in stroke volume and cardiac output. And because of that also causes back pressure, where left atrial pressures it will increase, and left atrial enlargement may be there, and it causes atrial fibrillation. And when it get transmitted to the pulmonary artery pressure, patient may go in for pulmonary edema. And because of increased circulating volume, patient is more prone for getting pulmonary edema, pulmonary congestion.
So when asked specifically which one thing is going to affect more, so what it will be?
Heart rate and increase intravascular volume.
Yes, increase intravascular volume. If you have to say one,
Increase
the
intravascular.
increased intravascular volume. Okay. So what complications do you expect in this patients, like if at all MS patient posted for any surgery or even delivery, like?
The patient early complications will be like when the patient goes in for labor, because of the pain and increased sympathetic drive, patient may go in for tachycardia and atrial fibrillation, new onset arrhythmias, or because following delivery there will be auto transfusion of blood from the uterus to central circulation, so that might cause pulmonary congestion and pulmonary edema.
Yes. So it is always the pulmonary edema and arrhythmias that you have to keep in mind for these patients. May it be delivery, may it be cesarean section, or your labor analgesia. Yes. Fine.
The patient was put on a lot of drugs during her pregnancy. This thing. So each drug will affect that pregnancy and the heart and the fetus in different ways. So what would be you suggest monitoring or this thing to the patient when you see the pre-op assessment?
Patient was on beta blockers, so she should be advised of periodic fetal heart rate monitoring because there may be a fetal bradycardia, and since she was on diuretic, amniotic fluid index monitoring should be done, and any features of hypotension or decreased intravascular volume. And since the patient is on low molecular weight heparin, she should be advised regarding to avoid any injuries because it may lead to excessive bleeding.
Suppose this patient is diagnosed to have mitral stenosis before pregnancy. What would have been your suggestion for that patient?
So patient is diagnosed to have mitral stenosis before pregnancy, and it is going to cause increase in NYHA classification 1 to 2 when patient plans for pregnancy. So depending upon the morphology of the valve and the subvalvular thickening or presence of atrial thrombosis, so patient may be advised to undergo, depending upon the morphology, either percutaneous balloon mitral valvotomy, open or closed mitral commissurotomy, and mitral valve replacement or repair accordingly to the lesion.
Okay.
Is
So
open
is there
commissurotomy done now? Valvotomy is done now?
Not now.
Oh, so why are you saying? Yeah, only the procedures that are done now you have to say. Okay. Yeah. Previously, you can just add like that. Previously, it was done like that. At least you can add. Yeah. But don't say the whole whatever is given in textbooks. Not like that.
is there any scoring system which would echocardiographic scoring system, which accordingly you can advise the patient?
It is based upon Wilkins score, which has 4 components. One is leaflet mobility, the leaflet thickening and calcification, and subvalvular thickening. So it has grade 1 to 4 each components, and if the grade is less than 8, it suggests that there will be optimum result from percutaneous balloon mitral valvotomy. If the grade is going to be more than 8, patient should be advised other options like surgical repair or replacement.
Okay. This balloon mitral valvotomy, will any patient, some patients will be contraindicated to undergo balloon BMV. So what are the conditions you say it is contraindicated?
So if there is presence of any left atrial thrombus or left atrial appendigeal clot, and if the valve is calcified, and when mitral stenosis is associated with the mitral regurgitation or recurrent effect of thromboembolic complication, patient will not be advised to undergo percutaneous balloon mitral valvotomy.
Okay.
What are the risk stratifications for maternal cardiovascular events during pregnancy?
So for maternal cardiovascular event or stratification, there are 3 scores. One will be Carpet score, which consists of presence of any features of cardiovascular congestive cardiac failure or TIA, an NYHA class of more than 2, and cyanosis, and history of any features of left ventricular outflow tract obstruction, and if the ejection fraction is less than 40. And Sahara classification, which also, if there is presence of arrhythmias or a history of congenital heart disease, or if the patient is on any medication, and cyanotic heart disease. And the modified WHO grading, which is classified into risk classes 1, class 2, class 3, and class 4. So class 1 patients, they have no risk of, no maternal morbidity or mortality risk. And class 2 will be, there'll be mild risk. And in class 3, there'll be moderate risk. The patient will be advised to go, she should undergo multidisciplinary approach, and she should be monitored throughout a pregnancy. Whereas class 4, there it is a complete contraindication for pregnancy. Patient will not be advised to get pregnant. And even if she gets pregnant, early termination of pregnancy is advised. So Carpet score, Sahara, and WHO grading. It is a maternal cardiac.
Do you want to start anticoagulation in this patient?
Yes, ma'am.
Like what?
So since a patient is antenatal patient, so drugs like oral vitamin K antagonists cannot be started at early pregnancy. It may cross the placental barrier, and there are high risk of teratogenicity. So patient may be started on low molecular weight heparin or unfractioned heparin.
Okay, and then continue.
So in early trimester of pregnancy, patient may be started on low molecular weight heparin, and in mid-pregnancy, it should be continued. And since this patient is posted for elective cesarean section, she should be advised to stop low molecular weight heparin for at least 48 hours prior to surgery. And then that can be converted to intravenous unfractioned heparin, 5,000 units 8th hourly can be given, and it should be stopped 4 hours prior to the planned procedure.
And when do you restart it again after the procedure?
So usually after 4 hours of surgery, so patient can be started on low molecular weight heparin, and after 24 hours surgery, oral anticoagulants can be started. And it depends upon the mode of anesthesia, which is, in case if the patient is epidural, it will change it.
Okay, 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 fine.
So how do you monitor a patient who is on low molecular weight heparin or unfractionated heparin?
So if the patient is on low molecular or unfractionated heparin, APTT should be taken, and it should be around 1.5 to 2 times that of the normal value.
Is it for unfractionated and low molecular weight heparin, or it's different?
It is for unfractionated and low molecular.
No, low molecular weight heparin APTT cannot monitor low molecular weight.
Anti-10A factor assay, sir, but
Yeah.
we are not using it. Practically, it is not done.
Yeah, practically it is not done. Okay. What are the cardiac risk stratification for non-cardiac surgeries? Usually it is used.
So for non-cardiac surgery, it is Goldman risk stratification score, and one will be Lee's modification revised cardiac risk index. So which will be classified as high-risk surgeries like intravascular surgeries, intrathoracic surgeries, suprainguinal surgeries, and if the patient has history of any ischemic heart disease, presence of Q wave in ECG, or history of sublingual nitrate intake, and if the patient had undergone previous CABG or PTCS, and associated with that presence of any CVA or diabetes mellitus, patient on insulin, and if pre-op creat is more than 2. So along with that, the other stratifications will be Eagles criteria and death scheme multi-system modified criteria, and Duke's criteria also, so metabolic equivalence.
Yeah. One thing I would suggest you is you answer particularly to that question. You don't try to tell whatever you have learned. So the question was, what are the criterias? But you started explaining some criteria. So you just name the criteria alone. If they ask particularly what is the factors involved in that criteria, then you tell them. Because when you start telling, then the mode of questions will be diverted or whatever it is. So just answer particularly to the question which is directed to you. Okay, that will be the better way, isn't it, ma'am?
Now, if you want to post this patient for some procedure, what investigations would you like to have in your hands to analyze to her?
Starting with complete blood count, blood count, hemoglobin, hematocrit, and platelet should be seen since the patient is on heparin therapy, and renal
Start with routine and specific.
routine and specific. So routine will be complete blood count, renal function test, serum electrolytes, coagulation profile, PTINR, liver function test, blood grouping and cross matching, and ECG, echocardiography,
I am pointing here something. Thyroid function test.
thyroid function test, and blood sugar, and ECG, echocardiography.
Specific. Now it comes in specific. Specific.
ECG, echocardiography for this patient.
Okay.
Specifically.
Now, what do you expect? What abnormalities can be present in hemogram?
Hemogram, since the patient is antenatal, she may have some physiological anemia, so hemoglobin hematocrit should be seen. And platelet count is important since she's on heparin therapy, so she may go in for platelet dysfunction thrombocytopenia.
Very
And
good.
coming to serum electrolytes, since she had history of hypokalemia, she was on potassium chloride syrup, so preoperatively it should be seen whether it is normal.
Very
And
good.
coagulation profile, PTINR, and liver function test for maintaining her anticoagulation profile post-operatively. And
Liver function test, some more. Go slow. This is now important part we have come to, right? So, liver function test. What is the importance of liver function test? See, why do you want liver function test? Why
if
will
it is in case deranged, the minimum cutoff, because since the patient has, she's on anticoagulant therapy, and pregnancy itself will be a procoagulant state, and patient is also on anticoagulant therapy. So if liver function test is deranged, we will modify the cutoff value for anticoagulant.
Okay, fine. That is one thing. Nextly, her right heart failure things.
Hepatic congestion, so when there is involvement of, if there is features of right ventricular dysfunction, right heart failure, there'll be derange, increase total bilirubin, or ALP, AST, everything.
Idea about that also. Yeah, right heart.
Hepatitis, ischemic
Yeah.
hepatitis.
Then KFTs. Anything? Anything? Do you
Renal function
expect
test.
anything in kidney function test?
Yeah, creatinine, serum creatinine, and because of hypovolemia, patient may have, but in pregnancy, the creatinine clearance will be increased and it will be of lower value.
Just say I don't expect any abnormalities in kidney function tests. Yeah. Then thyroid function test. Do you expect anything abnormal?
No, ma'am.
No.
Specifically, there is no abnormality.
Yeah. What if this patient had hypothyroidism? Is it going to affect? Just tell in one sentence, because it is very lengthy. Otherwise, it will go in another direction. In hypothyroidism and hyperthyroidism, are these things going to matter in MS and pregnant patient?
In hyperthyroidism, there will be increase in heart rate because of that.
So these signs and symptoms may probably
overlap between atrial fibrillation and hyperthyroidism.
Yes, yes. But
will not
that
be able to
cause problems in anesthesia. So thyroid function test is very important. Also, if it is hypothyroid, she may have bradycardia, but she's on beta blockers as
beta
well.
blockers. Yeah.
So you have to take care of both the things. Yeah. So that is why thyroid function test is very important. Don't forget it.
Yeah.
Now coming to specific investigations, INR and all we know.
Yes.
Now come to specific investigations. Chest X-ray. What all? Tell the findings. At least 10 findings.
So chest X-ray, there'll be features of left atrial enlargement, like straightening of left heart border, and double density sign, which is because of left atrial enlargement, and presence of stag antler sign because of upper lobe congestion because of pulmonary edema, and features of pulmonary edema. So there'll be presence of curly A lines, B lines, and there'll be increased cardiothoracic angle ratio if there is.
Will it be increased in MS?
In MS, it won't be increased.
Don't say. Don't say. Then?
An increased bronchopulmonary markings will be there.
Sickling of barium to allow healing of esophagus, something like that. Yeah.
Splaying of
Splaying of
carinal
cranium
angle.
is another thing. Yeah. And
Peribronchial cuffing will be there. Peribronchial
yeah,
cuffing.
yeah. And you have this pressure symptoms and pressure signs.
Esophageal involvement if it is there, and because of left atrial enlargement of or pulmonary artery enlargement, there'll be
Yeah, there will be sickling of the esophagus in the lateral X-rays.
lateral X-ray.
Okay. Hmm. Fine. Okay. And now ECG, what are the changes that you expect in ECG?
So because of left atrial enlargement, there will be bifid P waves. P mitral may be seen in lead 2, or features of right ventricular hypertrophy. And in atrial fibrillation, there will be RR interval along with absence of P waves.
Okay. So you expect left atrial enlargement, right ventricular hypertrophy
Hypertrophy and atrial fibrillation.
in this patient. Fine. So
So
echo
right axis deviation.
and right axis deviation.
Right
Right?
axis.
Yes. Echocardiographic changes, what do you expect in echocardiography report?
So valve morphology, whether it's thickened, calcification, leaflet mobility, subvalvular apparatus, and left atrial, any presence of clot or thrombus, and pulmonary artery pressures, pulmonary artery hypertension, presence of that, and right ventricular dysfunction, biventricular function, and or tricuspid regurgitation or other valve involvement associated with mitral stenosis.
So which chamber fails first in mitral stenosis?
My left atrium will get
Okay, fine. Which chamber? Left atrium, good. Now which ventricle?
right ventricle will get filled.
Right ventricle. Can left ventricular failure occur in MS?
Yes, ma'am. If there is associated with the postrobasal regional wall motion abnormality because of a consequence subsequent to the valve calcification or subvalvular apparatus involvement, or because of vasoconstriction which occurred as compensatory mechanism to reduce cardiac output, or and if there is increase afterload, the left ventricle may go in for dysfunction, or because of rheumatic myocarditis itself, the left ventricle dysfunction may happen.
Yes. And secondary to right ventricular failure.
Right ventricular failure.
So these are few. Otherwise, the LV is normal, but failure can occur due to all these things. Okay. Okay. Next, Vijay Kumar sir.
Yeah. Till now, I think we are talking all about medicine.
Yes.
Now we'll come to proper anesthesia part.
Yes,
So if this patient is posted as for elective LSCS, if this patient is posted as a first case in the morning around 8 o'clock, so how will you advise and how will you go about? Because you have investigated and everything. Now, how will you go about?
So first, informed and written consent should be obtained from the patient. And secondly, patient will be advised about nil per oral. So for solid food, she should be NPO since 6 hours and clear liquids for 2 hours. And a routine morning dose of beta blockers, digoxin, the penicillin, and diuretic should be taken at the morning of surgery. And anti-aspiration prophylaxis like zero point 0.3 molar sodium citrate 30 ml should be given 30 minutes prior to shifting time. And injection tranitine 50 mg IV 60 minutes prior to surgery, along with injection metoclopramide 10 mg 30 minutes prior to shifting the patient should be given in the morning.
Okay.
So you will put a IV line there itself.
Yes,
It is intravenous or intramuscular?
Intravenous, one IV line should be secured in the ward, and following that vision.
Fine. So you take the patient inside the OT now. Which anesthesia do you plan for elective cesarean section in this patient? Elective.
So for elective cesarean
So what
section,
was the mitral valve area in this patient on echocardiography?
it was 2, ma'am. It was between, it is mild to moderate stenosis this patient was.
It is 2. Okay, okay, but I'll give you a patient with 0.8 square centimeter. Okay, now you have to give anesthesia. So what preparations you are going to do? What type of anesthesia are you planning?
So since it comes under critical mitral stenosis, so the option of anesthesia will be general anesthesia for this patient, ma'am.
Okay, now
Okay.
Well,
How
I
will
want
you prepare your OT?
person wants to give epidural anesthesia. So how are you going to convince Vijay Kumar sir? No, sir, I want to give GA and GA is better. He is your sir, right?
Yeah.
So you have to convince Vijay Kumar sir that sir GA is better. We will proceed with GA. Now,
Since it's a fixed cardiac output and it is severe critical stenosis,
say
relative fixed cardiac output and it's severe critical mitral stenosis, patient will not be able to compensate the sympathetic blockade which occurs following the regional anesthesia technique. So and it is a severe
he
lesion
is
and patient.
expert over there. It doesn't matter for him all these things. Yeah, you have to convince properly, strongly. He is expert since 20, 30 years. He must be doing. His cardiac anesthesiologist upon that. Yeah, so he'll not be afraid of all these things. So, okay, tell me, spinal anesthesia. Are you going to consider spinal anesthesia?
No, ma'am.
Not at all. Why not at all?
Because if a spinal anesthesia, the sympathetic blockade, patient will not be able to compensate with sudden sympathetic blockade.
Uninhibited sympathetic blockade, right?
Yeah.
So
Patient may go in for cardiopulmonary collapse, cardio collapse will may occur following spinal anesthesia.
okay, okay, and since this is a pregnant patient, we have to deal with the baby also.
Yeah.
Yeah.
And the uteroplacental perfusion will be affected by that because of hypotension.
Yes. So I will not go for this hypotension severe, which is going to occur. So no spinal anesthesia. Now epidural or GA. Why not epidural from your point of view? Because of one you said sympathetic activity. More.
Since it is critical stenosis, it is ideal to go with the.
He is such a senior man. No, it doesn't matter. And you are in an institute also. It is not freelancing practice. Yeah. So you have a team, right? But still you are not convinced to give epidural. There are so many papers, research papers published. Yes, sir. Vijay Kumar sir, do you agree?
Yeah.
It is 7.8, right?
But as for exam point of view, any lesion mild to moderate, they will go for regional thing. Anything related to severe or critical, the textbook suggests as general anesthesia. So usually in examination, it's okay if you tell the general anesthesia for severe and
What
critical.
you have to say is, you have to say, sir, I will, or madam, I will be comfortable with this.
Yeah, correct.
Got it? Sir, I don't, epidural also is okay, but I am comfortable giving general anesthesia through this patient. Fine. So then I can't argue. If you are comfortable with that type of anesthesia, then I can't argue, right? So you have to say, sir, I will proceed with this because I'm comfortable with this. Yes. So now you tell pro and cons of epidural anesthesia first.
So epidural anesthesia, there'll be slow onset of anesthesia. So the maternal cardiovascular.
That time only I was expecting you first. This is very easy, no? It is time consuming, no? Administrating epidural is time consuming first.
Yes.
Then the slow onset of anesthesia. Yeah. So these also things are there. Okay, fine. But it is elective. That is why I said. So even if somebody wants to give epidural in this patient, it is okay.
Yeah.
So now tell whatever.
In graded epidural anesthesia, the onset of anesthesia will be slow. So the compensatory cardiovascular compensation will be there for the sympathetic blockade. And the peripheral pumping mechanism will not be affected. So, and chances of DVT are less. And a desired sensory blockade can be attained with incremental dosage. So patient will not be going in for hypotension, profound hypotension, which will be seen with subarachnoid block. And with epidural catheter in situ, postoperative analgesia can also be given to the patient since there are increased chance of complication during immediate postpartum period in mitral stenotic patient.
So they were pro. And cons. Now, what are the cons? Why should you not give epidural?
If the patient is on anticoagulant therapy and if the antic profile is deranged, the patient cannot be taken in regional anesthesia. And if there are local site infection or maternal, if patient refuses,
Okay.
we'll be going for general anesthesia.
Time consuming. Yeah.
Time consuming.
And then what about the hypertension and fluid management is so critical, you know? Yeah, that you have to say. Fluid management you have to do of epidural also. You have to give some fluid. And then there are chances of this pregnancy-related hypervolemia. And then your means chances of a patient landing into pulmonary edema are very high. Yeah. And you will not be able to know like it is due to which, like it is due to epidural or is it due to your fluid administration. Yeah. So any amount of hypotension will occur. You have to compensate with some fluid. Yeah. So then chances of pulmonary edema are high in epidural. But still people do prefer in point 8 also meticulously they give and they do prefer. Okay, do you want to do invasive monitoring in this patient?
Yes, invasive blood pressure monitoring should be done.
Okay, for point 8. Okay, fine.
For
What are the pro and cons now? I want to do invasive monitoring. I don't want to do invasive monitoring.
So with the invasive monitoring, we can anticipate any introp complications, like if patient goes in for pulmonary edema or any cardiovascular collapse, like if the patient is on arterial catheterization or pulmonary artery catheterization and or internal jugular vein cannulation can be done. And accordingly, we can give fluid therapy and
Fluid,
any introp
inotropes, yeah.
inotropes and multiple infusion if we require, we can maintain it with
And we
central
do
venous
the
blood
arterial
vessel.
monitoring.
And AB, if arterial line, there'll be beat to beat monitoring.
Yes. So your arrhythmias like AF
If
can be monitored better. Yes. And then ABGs can be taken.
ABG frequently, if we want to do, we
Now
can
I say I don't want to do invasive monitoring. So how do
If the
you?
patient is in under general anesthesia, we can go for transesophageal echocardiography, and
Okay.
we can continuously monitor the cardiac status.
But they say that it is a small procedure and the procedure gets over very fast. So you can just keep everything ready and induce the patient. Yes. If you have a team of anesthesiologists who are present over there for this patient, you can keep everything ready and then induce patient so that at any given point you can just invasively put the lines. So that way also it is there. Okay. Fine. What more, sir?
Basically, what are the anesthetic goal you want to maintain in this patient of pregnancy with mitral stenosis?
So in this patient, cardiac grid, that is the heart rate, rhythm, contractility, afterload and preload should be maintained. So heart rate should be maintained at around a low normal heart rate. And since this patient is already in atrial fibrillation, so AF with slow ventricular response rate should be maintained. And preload, afterload and contractility should be maintained. And at any point of time, we should not forget the uteroplacental, the left uterine displacement should not be forgotten. So we should avoid aorta cable compression throughout the procedure, and condition which causes increase in pulmonary vascular resistance should be avoided, like hypoxia, acidosis, hypercapnia, and pain should be taken care of intraoperatively.
Correct.
Yes.
So, if like ma'am was telling, if you are planning epidural, so what is how will you go about putting an epidural in this patient?
So
Step by
once
step.
the patient is shifted to the operation theater and all standard motors are attached, and after explaining the procedure to the patient, so patient will be put in left lateral position and the parts will be painted and draped. And after identifying the L3 L4 interspace, skin infiltration will be done with 2 ml of 2% lignocaine. Following that, with 18 gauge epidural 2 He needle, so the L3 L4 epidural space will be confirmed with loss of resistance technique. And once the space is confirmed, epidural catheter will be inserted. And test dose should be given after negative aspiration, that is 3 ml of 1.5% plain lignocaine should be given. And once the test dose is given, patient is turned into supine, and with the right wedge should be kept under right wedge and right side of the hip. and patient should be monitored for around 5 minutes. So to anticipate any intravascular or intrathecal placement of the catheter. And once the patient, at the end of 5 minutes, total volume of around 15 ml of 0.5% bupivacaine with 50 microgram of fentanyl should be given in incremental dosage, like 5 ml in 2 minutes interval should be given till the level reaches up to T4, and we shall start the procedure at that point.
So what level did you achieve?
So T4, up to T4.
Now suddenly a patient has started deoxygenating.
Yes.
The saturation has come to 88.
Yeah.
What?
So first we should check for other signs of, it may be amniotic fluid embolism, also sudden desaturation, or
First, what you will do instantly?
instantly we should increase oxygen to 100% oxygen should be given. And if the patient is hemodynamically unstable, we should secure airway, and 100% oxygen should be continued, and causes of desaturation should be sought.
Secure airway means you don't intubate, at least you keep the mask.
Yeah, mask.
Yeah, and then
100% oxygen mask.
you check the
And
level.
of, if it is high spinal or it is a total intravenous placement of catheter because of system local anesthesia toxicity.
Okay. Okay, fine. Fine. Okay. Now the saturation has come to 98. So how do you proceed?
So we can maintain with, if saturation is maintained with normal face mask with 5 liters of oxygen, we can proceed after checking the level of the blockade. And if the patient is comfortable and hemodynamically stable, we can proceed with surgery.
Okay. In the 5 minutes, baby is out. Now what next?
So once after baby is out, the uterotonic agents which we'll be asked to give, we should avoid bolus dose of uterotonic agents in this patient. So we can go for infusion, oxytocin 40 units. Infusion can be given in 30 minutes, and drugs like the other uterotonic agents like methyl ergometrin or prostaglandin should be avoided, since it may cause tachycardia, hypertension, and it may increase the pulmonary vascular resistance.
Okay. Now the heart rate has come to 140. And the BP is 110/70.
Yes.
What do you do?
So first we should check the ECG whether it is patient is already in atrial fibrillation and now it is in fast ventricular response. So since she's hemodynamically stable, we can go for intravenous beta blockers like esmolol can be given, and hemodynamic should be monitored.
Yes. But now 140 heart rate and 70 BP systolic.
So since the patient has become hemodynamically unstable, so it should be reverted soon with DC cardioversion should be done. After.
Is it immediately would you give DC shock directly?
After sedating the patient, since
Okay, that should be fine. With 70 BP, we don't think of sedation, right? So first we have to bring the BP up.
Yeah, inotrope should be started.
What inotrope?
Or if the BP is low, we can go for IV phenylephrine bolus can be given first, 50 to 100.
You think as if you are in the OT and you are managing the patient. So immediately you are going to give phenylephrine, right?
Bolus.
Yeah. Bolus, phenylephrine. Now the BP has come to 130. It comes, no? Immediately. Yeah. So now you are okay. Now you will be very meticulous and you will be very watchful and you will see if again it happens. Now you will keep your DC shock ready. Yeah. And everything ready. And you'll be vigilant. You will ask your senior to be there or somebody, one anesthesiologist to be there with you. Yeah.
Yes.
You will just anticipate more complications. Now, what more complications will you anticipate? Once AF has come, yeah, fast ventricular rate has come, yeah, hypotension has occurred. Now, what next can happen?
Pulmonary edema may also occur after delivery of the baby because of auto transfusion. Soon after delivery, there will be a shift of
fluid as also.
circulation. Yeah.
Then
So increased chance of pulmonary edema.
Yeah, you have produced some vasoconstriction also. Yeah. So pulmonary edema. Yeah. Now again your saturation has come to 85.
Now it may be because of pulmonary edema, like pulmonary congestion.
Edema. So what do you do?
So IV diuretics can be given. Start bolus dose can be given.
Auscultate also. Like we will auscultate in between. You'll ask somebody to auscultate. Yeah.
Yes,
So, but it has to be pulmonary edema. So it is the onset of pulmonary edema. So what next? Tell again 100% saturation.
100% oxygen, and morphine can be given. Then it can be IV diuretics can be given.
Yes. Stat, how much?
Furosemide 40 mg stat can be given.
Stat 40 we give, no, whatever we give, tell. And if the examiner says like 40, then sir, institutional practice. Got it? Yeah. So even we give 80, we give 100, isn't it?
Yeah.
This is our institutional practice, and look to your internal examiner. Yeah. And they'll support you. Like, yeah. So whatever you do, you tell over there. Yeah. Yeah. Then next. So what has happened? 85 was the saturation. Then you gave diuretic. You auscultate.
And
Yeah. And again you'll auscultate. Yeah.
Any chest signs, if crepitation was there, if it is reduced in intensity.
And you see if urine output is coming. Yeah.
Yes.
Yeah. Next. Later. 100 oxygen was there. So now your saturation has started coming up, 96, 98. So you keep the mask like that only.
Yes.
Okay. When will you intubate this patient?
If the patient is not improving with IV diuretics or morphine and 100% oxygen and hemodynamic collapse, like BP is on lower side.
One, BP is coming down. Second, saturation is not increasing.
Saturation is not improving. If the patient becomes unresponsive.
Oh, that is very far. Don't think of that now. Before that, you have to do something. You see, some secretions will come, no?
Frothy sputum, like pink frothy secretion. If it comes.
Not till then. Some secretions start just like saliva, something starts. Yeah, you get to know that immediately, right? Because you are watchful, no? Yeah. Then
it suggests that patient is in frank pulmonary edema. So we'll secure the airway with or endotracheal tube, and we'll.
How? What drug you have to give? As if you are in OT. Secure the airway is very this broad terminology, no?
Yes.
What will you give to secure the airway?
So we'll go with etomidate.
Okay, good.
And or fentanyl. Starting with fentanyl, we can go with 150 or 200 microgram will be given. And
handy in these cases, right?
Sorry, ma'am.
Opioids come very handy in these cases because they combat tachycardia also. Yeah. So fentanyl is like my favorite in these cases, right? So you give fentanyl how much?
5 mics per kg we can give.
What was the weight of this patient?
60.
60. So how much are you giving?
2 microgram per kg we can 180 or 150 microgram or 200 micrograms.
But do you give 100 directly?
We don't give 100 directly.
So, yeah. So tell. I give first 50. Yeah. Then watch. Then again add 50. Like that only we do, no? Gradually. Yeah. And then how much etomidate you will give?
Etomidate is 0.4 mg per kg. That is around 18 mg for this patient, ma'am.
Okay. So that comes to how much ml?
It will be
18 mg is how much ml?
4.
Okay, you will tell me later.
6.
No. So you tell me later. Fine. Now tell me, etomidate, how much you will give practically, you tell me?
0.2 to 0.4 mg per kg.
No. Okay, fine. That calculations you are going to do, and you will message me on WhatsApp you have, otherwise in the group, task group. Fine. So tell me, how much ml you will give in a normal patient, 50-60 kgs, how much ml etomidate you will give in this scenario? 3, 4, 5 ml, right? Not more than 5 ml, right? Yes, sir. Vijay, sir?
Yeah.
5 ml. Yeah. So 5 ml of etomidate maximum. I don't give 5 ml also because morphine also I had given to this patient. You had given morphine, right?
Morphine, fentanyl.
Fentanyl, then we have given maximum 10 ml. So yeah, first I can give 5 ml and then I can give another 5 depending upon the hemodynamics. Yeah. And then what? You want to give some relaxant?
Yes, ma'am.
What?
We use injections colon 2 mg per kg, which comes around 100 mg.
Okay, you'll give scoline.
Yeah.
You are like patient is hypokalemic and patient is
If not scoline, we'll
I
go
have
for
glycopyrrolate
rocuronium.
ready. You have to be like that. Huh. Say, okay, ma'am, I'll give scoline in spite of all these things because I have glycopyrrolate heart rate was also very high, so I can give ma'am succinylcholine. Okay, but I would give vecuronium. Okay, okay, fine. Then intubate the patient.
Yes, ma'am.
Now, the sputum has decreased. Sputum is the pink for the sputum has decreased. All your drugs, fentanyl, and everything. No, now heart rate. Now BP has come to 60, and 180 heart rate. Now what you will do?
Since BP is, we can go along with that, and if the patient is hemodynamically stable and there is no features of raised pulmonary vascular resistance, we can extubate the patient. And pulmonary, there is no features of raised airway pressures. We can revert and we can extubate the patient on table.
I am little skeptical. I don't know Vijay Kumar sir's view. The patient who has been like in the initial stages of pulmonary edema, who cardioversion has been done, inotropes have been started. Yeah, Vijay Kumar sir, would you like to explain?
Nothing wrong in ventilating the patient who has been given a shock intraoperatively and who have started on inotropes. So nothing wrong in ventilating, and in fact, it will be beneficial for the patient to be ventilated for a couple of hours post-operatively, because immediate post-operative period is the one where more of auto-transmission is going to occur. So it's better to ventilate the patient for a couple of hours, then you can extubate the patient later in the ICU.
So this was some critical management, patient management of a very critical patient. Oh, okay, MS running a very critical and takes different course. Like so you have done well in this. Now you can go for the simpler case, wherein you can just give epidural anesthesia, or you can give, if you want to give a GA for like 1 millimeter, 1 square centimeter MS. Okay. So now tell me, in which cases only GA we have to give? Are there any cases where only G has to be administered in MS case?
If the coagulation profile is deranged, we can go only for general anesthesia. And regional anesthesia, there will be increased risk of hematoma formation will be there, ma'am. Okay. So general anesthesia should be
very
given.
critical MS. Okay, 0.6 or so. Yeah. Then some more. MS with CCF, MS with pulmonary edema. Yeah. Then MS with prosthetic valves, other prosthetic valves if they have. Yeah. Then also if they have multiple valves involved, then also you have to go for only GA. Like if it can't be given in these patients. Yeah. Okay, tell me something about pain management in these patients.
So multimodal analgesia should be followed. Injection paracetamol 3 gram per day in divided doses can be given, or opioids, IV fentanyl can be given incremental doses in boluses, or fentanyl patch, or while shifting we can give transverse abdominis plain block.
Yeah.
So suppose I will just ask one question. If a patient is on during surgery and baby is being delivered, suddenly patient starts saturation coming down and BP falling down, what would be your diagnosis? Or how will you differentiate your diagnosis?
One differential diagnosis will be amniotic fluid embolism.
That is one diagnosis. What would be the other cause? Usual cause will be pulmonary.
Pulmonary edema and
So how do you differentiate? This will be pulmonary edema and this will be amniotic fluid embolism. Is there any finding which you would clinically you can differentiate both? Because management almost is same, but there will be different little difference will be there in the managing pulmonary edema and amniotic fluid embolism. So how will you differentiate clinically amniotic fluid embolism from pulmonary edema?
in amniotic fluid embolism, patient may have features like cutaneous flare or bronchospasm, and if CNS manifestation like seizure, or if the patient has gone in for coagulopathy, there'll be increased bleeding from the surgical site, so which will not be seen in case of pulmonary edema. And the diagnostic feature is the aspirate which will be taken from the CVP. It will show presence of fetal mucin histopathology.
So how will you manage amniotic if it is diagnosed as amniotic fluid embolism? How will you manage?
So for patient should be given 100% oxygen and positive pressure ventilation and IV diuretics and prophylactic antibiotics and steroids. Injection hydrocortisone 200 mg can be given. If associated with hemodynamic compromise, if patient's BP is low, we can start drop infusion.
Okay.
Suppose the obstetrician for this case she wants to have a normal delivery. Patient is post normal delivery, but obstetrician has to assess. Then how will you plan your anesthesia for that normal delivery?
Or labor analgesia.
Yeah.
So in early stages of labor, patient can be given a combined spinal epidural. So intrathecal dose of fentanyl 25 microgram can be given. And when that progresses to second stage of labor, since the epidural catheter is in situ, we can give incremental dose of local anesthetic with opioid, like 5 ml and 2 minutes duration till the level goes higher. And that can be continued for post-op.
No, you have to be specific. You can't say local anesthetic with opioid. What you have to give, you have to say.
0.1 to 5% bupivacaine.
Yes.
With 25 microgram of fentanyl, we can give 5 ml in incremental dosage and 2 minutes interval can be given throughout the second stage of labor.
So anything specifically you will do in second stage of labor in normal delivery? Some instrumentation you have to do to decrease
we should cut short the second stage of labor with the help of outlet forceps or vacuum extractors can be used to reduce maternal effort. Like
Okay. Now, because this case, it was MS case. So many a times these are like occult cases. No? They directly come. They don't come for follow-up and all. Yeah. So at this time, these are the periods like where this pulmonary edema or arrhythmias do occur. Yeah, like this second stage of labor and all. Yeah. So because if now this was a worked up patient, so MS patient with ECG, echo, chest X-ray, everything was there with investigations. Sometimes in small town places or in small nursing homes, they come directly for cesarean section only. Yeah. So at that time, even the murmurs are not could not be auscultated. It happens like that. So these are the stages where you have to be very particular, like second stage of labor. Yeah. This is one particular time when pulmonary edema can occur. Yeah. Now, the pathophysiology of MS is remaining. I want to hear a very nice pathophysiology description. If sir permits, we can take it later also.
Yeah, we'll finish it up now. Okay. So we'll continue, finish up this anesthesia questions, then we can go back to yeah. So I'll just give one scenario. Suppose if this patient was operated previously and he is on prosthetic valve implanted in the mitral area, and she becomes pregnant.
Now this
and
goes home. So what sir wants me is, now this patient goes home after your good management. Yeah. Next year she gets operated for a mitral valve replacement, and the next year she comes again with 9 months gravida. She comes now again posted for previous LSCS, so posted for cesarean section. Now how we will manage, sir is asking.
So since patient will be on a prosthetic valve, or patient will be started on oral anticoagulants, so that should be taken care of prior to surgery. She should be started on low molecular weight heparin prior to surgery, and it should be advised to stop 48 hours before surgery, and should be bridged with unfraction. It should be changed
you will
to
stop
unfraction
vitamin K antagonist 48 hours before surgery.
Vitamin K antagonist will be stopped for 5 days before surgery, and patient will be bridged with either low molecular weight heparin or unfraction heparin. And 2 days prior to surgery, PTINR should be checked for. And if it is normal, we'll be stopping in low molecular weight heparin, and we'll continue with unfraction heparin IV 5,000 units 8th hourly. And prior to the planned procedure, we'll stop 4 hours before the surgery.
So if it is a prosthetic valve, will you consider regional anesthesia or general anesthesia for this patient?
If prosthetic valve, we'll go for general anesthesia.
Why? If all bleeding parameters are normal, you can go for because valve is normal, valve was replaced. So if all coagulation parameters is normal, you can go with regional anesthesia. Okay. If the patient comes for emergency surgery, suppose a patient with prosthetic valve coming for emergency surgery, then how will you manage?
During investigation, all baseline investigation should be first taken for this patient, and especially coagulation profile should be checked, since the patient is on vitamin K antagonist oral anticoagulants, and we should optimize the coagulation profile prior to surgery with fresh frozen plasma transfusion.
What coagulation profile you will see?
PTINR should be seen,
okay.
PTINR especially, and it should be corrected with fresh frozen plasma, and patient will be taken up for surgery, and the plan of anesthesia in this patient will be general anesthesia. Since the patient was on anticoagulant and prior period of stoppage, it was not there, so it is better to go with general anesthesia.
Good. So I'll give one more scenario. This pregnant patient, elective LSCS, your plan, and patient is in theater, and your plan is, as you told, it is graded epidural lumbar epidural. So you have planned that, and you are putting an IV line and an arterial line. Immediately after placing an arterial line, patient started fibrillating. Okay, so how will you manage this patient?
So first we'll call for help. We should call for help, and we should start CPR for this patient, and we should check whether there is a wedge kept under the right hip, and prevent eye to cable compression, and 100% oxygen should be given, and defibrillator paddle should be attached to the patient, and we should recognize the rhythm, and accordingly we'll deliver shock of 200 joules. Cardioversion should be done, and by that time we should activate the obstetrician as well as neonatal resuscitation team, and if the patient is, we should secure airway with oral endotracheal tube, and we should initiate surgery should be started. 4 minutes till 4 minutes we'll be checking whether the patient is hemodynamically stable, or there is the rhythm has come to normal sinus rhythm. In case if beyond 4 minutes there is no reversal of the rhythm, we should plan for perimortem cesarean delivery. If in case the delivery was not done before, we should immediately activate the team, and we should follow the protocol for perimortem cesarean delivery.
Okay. So basically the question is, what is the difference between CPR in pregnant patient and CPR in non-pregnant patient? That is the answer which has been expected. So is there any difference in the compression in pregnant patient?
And compression you have to tell, right?
Yeah.
Why will that perimortem level come? You have to keep on doing CPR, right?
After delivering shock, compression should be again started, and for 2 minutes we should continue and then check for any pulse at the end of 2 minutes.
Drugs. Between you have to give drugs, everything related to CPR. Because this is basic. If you fumble in this, no, it is not good. Yeah. So CPR, no. Once that word comes, just start the flowchart, whole of the flowchart, an exact flowchart. Yeah. So tell us a little bit. If not,
just reconcile and tell me if this patient has been start fibrillating. So how will you proceed? Just think and tell.
Just points.
So we'll call for help. We'll start CPR by the time, and we should continue CPR. Uterine displacement should be taken care of, and defibrillator paddles attached, and we'll assess the rhythm. And airway should be secured by the time, and chest compression should be high standard. Assessing the rhythm and defibrillation is given. We should again continue CPR.
What is the compression ventilation ratio?
So if the patient is no chest compression should be continued at a rate of 100 to 120 per minute.
100 per minute. And you should be very careful. You should not over-ventilate the patient.
About all these things, okay? This is very
okay. So, what are the common causes for maternal cardiac arrest during surgery or anesthesia? What are the common?
Aspiration, hypotension, airway collapse, and bleeding coagulopathies, like if the patient has a uterine atony or placenta previa, placenta accreta, and cardiac causes like if the patient has congenital heart disease or cardiomyopathies or myocardial infarction, and drugs like oxytocin or magnesium or any drug errors, and embolic complication if a pulmonary embolism, amniotic fluid embolism, and the general causes of cardiac arrest like hypo or hypokalemia, hypotension, hypothermia,
5H and 5Ts.
and 5H and 5Ts.
Yeah. So you were telling about cardioversion. So what is the difference between cardioversion and defibrillation? Is there any difference?
So it is a synchronized shock, it is cardioversion, and asynchronized shock will be defibrillation.
Okay. Which this thing you will synchronize to what in ECG? You will synchronize to? So
there should be a definite QRS complex for that, and at the start of our way, we will be synchronizing the shock and delivering. So.
Okay. Madam was asking about the pathophysiology and hemodynamic changes of
questions are remaining, which I want like detail. Tell me about. One is pathophysiology, and second is pressure volume loop in MS. That also has to be discussed. Yeah. So you can start with any of it.
Pressure volume loop in mitral stenosis, there will be leftward shift of the pressure volume loop. Because there is reduction in the preload, that is, then the left ventricular and diastolic volume and pressure will be reduced. And the width of the curve will also be reduced because of the decrease in the stroke volume. So there will be leftward shift.
Loop first, normal pressure volume loop. Can you explain?
So normal pressure volume loop, the first point will be the um, filling, early filling, and the point 2 will be the isovolumetric contraction phase, and the point 3 will be ejection phase, and the point 4 will be the ventricular relaxation phase. And there are points where
So these are the events that you have told. Yes.
the point A will
Mitral valve. What happens
so
to
mitral valve will initially closes, and once the isovolumetric
initially close knee? Will it close? This is diastole, no? So mitral valve has to.
open, it will be remaining open.
Yeah. So first point, yeah, near the baseline, it is what?
Mitral valve will be open there, and at the second point it will be closed, and that will be followed by isovolumetric.
What? Don't be in hurry. Yeah. So this phase is what?
This is the filling phase, diastole filling phase.
Mitral valve will close here. Now what will happen?
After it gets closed, there will be isovolumetric contraction will be there. So, and there aortic valve will open at the end of that point.
Going up. Yeah. Yeah. And then what?
That will be followed by ejection phase.
Yeah.
And where aortic valve will get closed at the end of that phase.
So the pressure will fall again.
Yeah, pressure will fall again.
That is, now you understood all the 4 points.
Yes,
yeah? And the events. Okay. Now what happens in MS?
There will be reduced left ventricular end diastolic volume.
Yeah. So the
points will be leftward shift will be there in the curve.
Yeah.
And the stroke volume, the width of that graph also will be reduced because of reduction in stroke volume.
Yeah. First filling is less. Then
the isovolumetric contraction phase also, it will be reduced.
So it will be also less. Then ejection and the relaxation phase.
Relaxation.
Why it is leftward shift and why it is smaller.
Yes.
Right? Fine. Now describe the pathophysiology of MS.
So because of the obstruction due to stenotic lesion, so the left atrial pressure gets increasing. So because of increased left atrial pressure, there will be fibrillation, and prolonged left atrial enlargement, left atrial pressure increase, it will be transmitted to the pulmonary venous and arterial pressure. So pulmonary arterial hypertension will set in, and which may get transmitted to the right ventricle and may cause right ventricular dysfunction along with tricuspid regurgitation. And in case of forward flow theory, because of obstruction stenotic lesion, there will be the left ventricular filling will be reduced. So when left ventricular filling is reduced and the stroke volume will be reduced, so cardiac output will also be reduced.
I tell you once nicely. So use of words is very important because they have given you some limited time, like half an hour to 45 minutes. Yeah. So make proper use of words. Like see, in mitral stenosis, the mitral orifice area is reduced. Yes, which causes a gradient between the left atrium and the left ventricle. Gradient. So that word has to be used. Normally there is no gradient, but here the gradient occurs, and as the stenosis increases, this gradient increases. Right? So because the gradient increases, the left atrial pressure goes on increasing to for the left ventricular filling. As the left atrial pressure goes on building up over a period of time, it causes left atrial dilatation and left atrial enlargement. Because of left atrial enlargement and dilatation, the nerve tracts get distorted, which leads to various arrhythmias like atrial fibrillation. Because of increase in the left atrial dimensions, also there occurs stagnation of blood in the left atrium, which leads to thrombus formation. This stagnation is also called as LA smoke or LA.
Acoustic.
Yes, LA smoke, or it is also called as spontaneous echo contrast, SEC. Okay. Now this increased pressure in the left atrium gets transmitted backwards into the pulmonary system, giving rise to leads to pulmonary arterial hypertension. This pulmonary hypertension eventually has a back pressure effect on the right ventricle, which causes right ventricular hypertrophy. Because of right ventricular hypertrophy, there is annular dilatation of the tricuspid valve. Hence, there is this tricuspid regurgitation which occurs. Later, after the tricuspid regurgitation, the RA enlargement can occur. So, eventually, because of tricuspid regurgitation and pulmonary hypertension, right ventricle starts failing and right ventricular failure may ensue. Because this mitral valve has been stenosed, the left ventricular diastolic volume is reduced. Therefore, the stroke volume through the aortic valve is reduced. Hence, this is a relatively fixed cardiac output state. Okay, so I've explained very nicely. Yeah, you see this properly, and it has to be told like this only. Then you get the maximum marks in exam. Okay, nice. So over to you, sir.
Yeah, I think we have covered everything.
Yeah.
And what are the normal pressures in different chambers of the heart? Because if you want to know what is a pulmonary hypertension, you want to know what is a normal pressure. So can you tell me what are the different pressures in different chambers of the heart?
So in right atrium, it will be around 2 to 5 millimeter of mercury. In right ventricle, it will be 20 systole, and diastole may be around 5 to 8 millimeter of mercury. And in pulmonary artery, the systole will be 20 to 25 millimeter of mercury, and diastole will be 8 to 12. And in left atrium, it will be around 8 to 12 millimeter of mercury. And in left ventricle, it will systole will be 100 to 120, and diastole will be 8 to 12 millimeter of mercury.
Okay. So if you put a PA catheter, so how do you identify whether it has entered the artery or not?
So the diastole pressure will change when it goes from the left ventricle to the pulmonary artery.
Not left ventricle.
Sorry, right ventricle to the right ventricle to the pulmonary artery.
Okay. So anything else you want to ask, ma'am?
Dr. Meera, was it exhaustive?
Yeah. Now, the confusion between right and the left ventricle.
That usually occurs in exam, no?
Yeah, very well. And yeah, we wanted to emphasize, and I actually wanted to tell you the ideal way to describe it, you know. So I think you got it, and you have done very well, and you are going to pass with flying colors, no doubt. Yeah. And Vijay Kumar sir is there to guide you over there. So that is so good.
Actually, it's very well. I should say that
thanks this thing.
Dr. Meera has done an extensive preparation, and she will be given.
Dr. Meera, I just want to tell you that you have visited my website. That on my website www.cardiacanesthesia.in. Even if you don't remember, just Google Amarja Nagare, the website comes, or Google Cardiac Anesthesia website, it comes. In that, there's a section called Case Discussion. In that, MS case is there, and more than 100 questions have been answered over there. So once you go through that before your exams, it will be very useful for you all. Yeah, thank you. Thank you so much.
Thank you, Dr. Amarja. Thank you, Vijay Kumar sir. I think you are given selfless time and energy and effort to this case presentation and discussion. I think definitely if I would have presented, I would have failed. So
that's true. Amarja is a very tough examiner.
I was not harsh, no, on Dr. Meera.
No. It was an excellent.
Yeah.
No, she was equally tough. She was equally tough also with you. She was answering.
Well done, Meera. You did very well.
No, what is that now? Use of words within that stipulated time, you have to impress them. Yeah. And you have to tell them that you are eligible to go and give anesthesia tomorrow all alone. Yeah. Yes. That is the main thing. And Vijay Kumar sir, you will appreciate that very nicely we discussed that critical case scenario.
Yeah, correct. One by one we have
very well.
Done. And I have to thank Dr. Amarja. It is more of a teaching session. She has taught so many things. So instead of it is a Viva session, she has taught so many things.
Yeah,
And
because know the ideal, know how to answer.
correct. Yeah, correct. And particularly for the postgraduates who are listening to this, I want to mention one thing. In the exam, you direct your answers particularly to the question. You don't deviate and tell whatever you have learned or studied. So that will deviate the entire question session. So you try to answer precisely to what the questions. So you answer the questions alone. Don't try to elaborate your answer. Okay, so that means that you will you will answer it very short, and a lot of questions also will come to you, and you can impress the examiner with a lot of answers. So don't deviate from the questions. That is what I just wanted to tell.
Dr. Meera, you have to actually practice the answers.
Yeah, correct.
Your friends. You have to ask your friends questions and you all have to practice the answers. Yeah.
Correct.
I think she's frozen.
So I think that was a great session. Yeah.
Yeah. Great.
Thank you.
A way of organizing. Almost it is pan India. It is so many viewers are there, and so much of beneficial this thing. So they come across so many examiners. So many inputs. Different examiners view the same case in different angles. So they will come to know a lot of answers, lot of questions. So they will come to know. So